everyone. Communities see the impact of early rehab every day, but where's the data? Across hospital systems, virtual care, and home health, occupational and physical therapy professionals guide patients through recovery after birth and surgery. Still, health systems often struggle to measure the true value of what we do. Joining me today are two past presidents of the American Occupational Therapy Association, whose leadership has changed how our profession defines and demonstrates value in rehabilitation. Dr. Amy Lamb and Dr. Alyson Stover. Dr. Amy Lamb served as the president of AOTA from 2016 to 2019 and delivered her presidential address, Unlocking the Potential of Everyday Opportunities, at the American Occupational Therapy Association's annual conference. In that address, later published in the American Journal of Occupational Therapy, she said occupational therapy practitioners can embrace the distinct value of occupational therapy by harnessing the power of authenticity in our daily practice. In a separate interview with James Madison University, she described occupational therapy as a valuable investment as a result of the impact you make in the everyday lives of the people you serve. Her words remind us that our work has measurable value, yet systems often lag behind in recognizing it. Dr. Alyson Stover, who served as the immediate past president of AOTA, brings a dual background in occupational therapy and health law from the University of Pittsburgh. She continues to bridge policy, research, and practice to help therapists demonstrate system-level impact. On the OT Potential podcast, she commented that artificial intelligence is the partner OT needs to shift healthcare towards prevention. That statement reflects her focus on innovation and measurable outcomes that make prevention, not reaction, the center of our healthcare system. Together, Dr. Lamb and Dr. Stover have challenged our rehab profession to move beyond waiting for perfect evidence and instead design ways to measure and communicate the value we already deliver every day. Today, we'll explore how occupational and physical therapy practitioners can close the evidence gap in maternal health and how we move from what we see working to what health systems can finally recognize as evidence. Dr. Lamb, thank you so much for joining me. I'm actually really excited to know recently that you really have a passion in women's health and the coaching that you do and just bridging this gap that we're talking about with maternal health today. Can you just introduce a little bit of your background and how it lends well to the topic that we're discussing?
Yeah, absolutely. So, thanks, Rebecca, again for having me tonight. Like, this is such a fun conversation to be able to have with you. I really love the area of women's health. And so within the last 5 years, I added on some new credentials. I added some coaching credentials, and I was working with women who were seeking C-suite positions. So I was doing more executive coaching. And oftentimes what I found out was while working with these beautiful, amazing, wonderful women was that they had health challenges that were getting in their way of being able to achieve their goals. And that really brought me back to my OT background, where it was like, we're not addressing the root cause issues for women. And so I decided to go back and get my women's health coaching certification and pivoted into that space. And I have to tell you, it's been the most beautiful blend of occupational therapy and helping women to be able to make their life better, have an accountability partner as they're trying to make those lifestyle changes, and also just to have a sounding board of somebody who can say, listen, this is hard. Let's work on this together and troubleshoot how to get you to where you want to be. And I have just really enjoyed working with women's health all the way from maternal health to perimenopause and menopause, like the whole spectrum. And it's just been a real gift. And I feel like it's kind of been a culmination of my practice being able to come together.
You bring in so many, I think, especially at the C suite level, you bring in so many considerations, I think, with um, the intersection of just expectation of a lot of whether that's imposter syndrome, a lot of stress, a lot of responsibilities also in the role that we have in our families, and just really intersecting that with career advancement and everything. And I think that where I think the audience really is centered on with maternal health, especially, is that there is this expectation of returning to those roles of motherhood so soon, without that guidance that we would lend as rehab therapists to other populations in similar states. And at least in terms of the audience that's here today, a lot of those questions, Dr. Lamb, center around the evidence of actually offering occupational therapy services to those patient populations so acutely after giving birth. And I often think of how many of those patients I treated that were C suite executives, that were physicians themselves. And I was in their room as a physical therapist, understanding that there's another counterpart that's missing to this conversation. Where's my occupational therapy colleague? And I would really love to discuss that with you in terms of just a big bird's eye view of what people can expect tonight. What's your gut reaction to just to those situations that we often see ourselves in?
Yeah, I think you so beautifully like articulated the challenge that clinicians face each and every day, right? We walk into a situation and we're like, I have value here. There is so much I can do in this space. I know that what I'm going to do is going to be impactful for this person that I'm working with. And what I think we really need to do though is also step back and say, we need to produce the evidence that shows that it's not just for this one person, it's actually for the whole population, right? So we need to think about like, how do we do that in a way that is accessible for clinicians, that makes sense, that is not overly complex. You do not need to have a PhD to do some of these things. You can be a clinician who is frontline and working on showing like how the science in the implementation process is such a critical piece. And that's really, I think, the emphasis that I see here is it's that implementation science part of what we know our value is, and how do we bring it to a higher level and help people see that we're not just impacting one person at a time, we're actually making a massive change and impact with populations, and articulate that to funders and leaders within healthcare organizations as well.
I actually asked Dr. Stover to join us tonight, and then when she recommended, please like include Dr. Lamb in this conversation, I was over the moon to have you both with in this discussion. But it was Dr. Stover that actually brought to my attention, especially what you're talking about, Dr. Lamb, the book by Dr. Marty McCary, who's a Johns Hopkins surgeon and also public health researcher and the current FDA commissioner. And it's in The Price We Pay, What Broke American Healthcare and How to Fix It, where he said that, of course, no one has ever done a trial in which patients were randomized to have elective back surgery without first trying physical therapy. No one's ever done that study. Randomized trials done just to prove such a point would be unethical. And I brought you here today because I'm in a state where I'm needing consulting work myself. I have hospital systems that we're tracking, really through one of the first databases that was created for the purpose of tracking hospitals in the United States that offer occupational therapy and physical therapy on the maternity unit. It's the only one that we know of that exists. And the hospitals are coming to me now. Rehab leaders are asking, well, what are the data? What's the data that we can collect? What are the studies that we can do? What are the randomized trials? What do you suggest we use to show our value to the system? And I really want to discuss that with you today because implementation science was actually not in my vocabulary before I spoke to Dr. Stover, at this year's OTs and Pelvic Health Summit. So I want to ask one question to you, Dr. Stover. For those therapists, um, from your perspective, especially with rehab leaders, why are randomized control trials often not the best fit for rehabilitation research? Why not RCTs?
It's a great question, right? But actually, I think that those of us that are practicing in the rehab field think it's also a very simple answer, right? Because we are never evaluating or intervening for a diagnosis. We're not diagnosticians. We don't need a diagnosis in order to tell us what we're going to do, right? We need to see the effect on function from the symptoms that are presenting for that individual in that diagnosis. So I would never be able to pool the same exact human experience to conduct a meaningful randomized control trial. I am working in a capacity that I'm not diagnosing. There's not going to be a certain indicator that says, yes, everybody with this indicator has progressed or everybody with this indicator has regressed, right? It's going to look different from person to person because we are working with function. We are not working with diagnosis.
So then, how does that actually um, pair well with what you were talking about, Dr. Lamb, with implementation science and actually showing on a systems level, on a population level, we're making an impact for a whole population rather than individual impact, which we would document in our everyday, rehabilitation practice. How do we actually show that rehab is making an impact on the system?
Yeah, absolutely. I think one of the things that we have to recognize is that, and I think that this is so important to think about when we're thinking about research and your conversation with Dr. Stover about the RCT, right? Real life is messy and rehab is messy. And so the truth is that when when we're used to measuring what happens at the individual level, um, our hospital and leaders are trying to think. They want us to look for something different. They want to know, how are these services impacting the system? They want to know, how is what you're doing going to help prevent readmissions? How is it going to increase cost effectiveness? How is it going to improve this mother's transition to home, right? And that's where implementation science comes in, because it helps us show not only what works, but also how we get it to work in the real world and what's the cost of it. And hospitals care deeply about several things: length of stay, readmission, staff workload, the patient experience, and cost. Those are the fundamental things. And so we know, as OTs, as PTs, like, we know that we can influence these things. But the next step is to be able to prove that that's working, and then documenting how we roll it out to be able to sustain it and to be able to carry it through. So implementation science kind of helps us identify, like, these are the ingredients that we need. This is the training time that we need. These are the workflows, or if we need some changes to an EHR or something like that, and compare it to the benefits. And so that's how we then begin to talk to leaders about, this is your return on investment for this program that we're creating for you. And the thing I love about implementation science is that you don't have to start with a $1 million grant to fund what it is that you want to study. You can start with a small quality initiative where every person after having a C-section gets a OT or PT mobility visit within 24 hours. And from that, you can track what's the percentage of eligible patients that you saw, what was their average length of stay, what were the average number of, like, nursing assist calls. And as you are tracking that, you see improvement, and that becomes your preliminary data. And this shows that it's working in the real world, and it's feasible, and it's sustainable. And this is a way that frontline therapists can really enter into this space and not feel like I need a PhD to be able to do this. It's really just a way of structuring what they're already doing and thinking of it as, let's test it, let's track it, let's improve it, and let's keep going. And that's really where the implementation science, when it hits the road, has the ability to have great impact and also show our value to administrators along the way.
A question about that, and please chime in also, Dr. Stover, with this, is that, are patients in these studies being randomized to a group that receives these interventions at all?
No, no.
No.
So look, how do we actually treat, right? So what a randomized control trial does is it is beautifully built to look at the science, the biological, the physiological, the pathophysiological mechanisms of one actor on a system, right? What implementation science and really quality improvement does is it says, okay, so now let's take a look at what real life consequences or benefits are occurring. And in implementation science and quality improvement, one of the things, the freedoms that you're given that is beautiful, is the idea that when something is not working, you change it immediately. You don't have to wait until the study is done. You're looking and you're saying, hey, you know what? We're doing this one mobility visit postpartum with every woman that has had a C-section. But, we're getting a lot of pushback from the women. They're not wanting to participate. They're having low scores on the Pittsburgh Rehabilitation Participation Scale, right? Like this is something's wrong. Oh, well, maybe it's that we need to educate them prior to delivery that, you know what? This is the benefit of having early mobility within the first 24 hours. You don't need to wait then for that study to be concluded. You actually get to implement that right away. And that's where administrators are really, there's two things that I think about from that sort of legal lens and training that I have. One is that the idea that policy and law has always been written for the most vulnerable. Because when we write policy for the most vulnerable, those who are not experiencing that type of vulnerability will still benefit, right? So if I create a law that requires a business to be accessible to those who have difficulty or impairment with mobility, those who do not have difficulty or impairment with mobility, like with an electric door, they're also going to receive a benefit, right? We think about, and RCT is not looking at the most vulnerable. RCT is looking at the effectiveness overall of the intervention or actor that you are choosing to impose on the system. Implementation science is saying, you know what? That woman may not have needed to get up in the first 24 hours after the C-section because she already is very active prior to. She actually was engaging in similar movements on her own, right? But is it going to cause harm that she had that experience? Absolutely not. And so one is RCTs don't allow us to look through the lens of when we write policy and protocol and healthcare delivery for the most vulnerable, actually all benefit. And two is implementation science asks us to fail quickly and pivot faster. So when we fail, pivot immediately. And business has long embraced this concept. Health tech embraces this concept. It's one that really we are expert at. We fail fast. Oh no, this isn't working. We pivot quickly. What are we going to try next with our client? Implementation science is quality improvement, and quality improvement is rehab intervention.
I have a short story, but I first have to tell you both. I was at the Education and Leadership Conference of the APTA, And this was just a few weeks ago, and I brought up, kind of hinted at the talk that I would have with you both about how we may find ways to pivot. And I was talking with researchers who have published books and that are taught to Doctor of Physical Therapy students. And I was just dropping in ideas of how we may pivot in rehab research, rehabilitation research from these RCT driven studies that we're after to more of this implementation science using language that I probably had no business using at the time, but really just trying my training wheels out to try to understand this and conceptualize it. When I tell you the stares that I got, it was almost as if I started speaking in a different language. I mean, Dr. Stover, the way that my face was probably when you first told me this was 10 times probably not nearly the reaction that I received, from these very, very well-known researchers. And so my question really for you both is just taking a step back, even from the maternal health population, why does implementation science feel so foreign in terms of how we think about data collection and research and demonstrating our value in rehab, but then also feel like this is what we do every day. We work as part of a system to reduce hospital admissions, readmissions, to shorten length of stay, to make sure that that person's discharge location is appropriate. We do this every day, but why does this feel so foreign to study it?
So do you mind if I jump in first, Alyson, on this?
No, go for it.
So I have, so I also have a background in design thinking, human-centered design and design thinking. And design thinking is about designing solutions for people that actually get to the root cause of the problem, right? So you start by building empathy with a group, and then you ideate, like you really understand what some of their barriers and challenges are, and then you co-create and ideate some solutions, and then you try them, and then you collect data, and then you fix your prototype with whatever you learned in your data, and then you do it again. And it's a very rapid cycle process, right? And it's very much the same thing when I think about implementation science. And I love that you brought up the time, your time at the conference, right? Because I think what you also are bringing up is that there is a barrier that exists between our academic community and our clinical communities, where there's a sense that rigor and high quality research needs to look a very particular way. And what we know, though, as clinicians, is that healthcare moves fast. People's lives move fast. And if we don't move fast with how we're finding the solutions that are needed, we're going to get left behind. And that's where, as Alyson was talking about, like with the quality improvement and like the plan, do, study, act cycles, right? Like these methods are faster, they're practical, and they're built for clinical environments. And so I actually believe that in the academic world, we need to be spending more time teaching our students about implementation science. And we need to be teaching them, what does this look like on the ground floor in the clinic? Because they're not going to be doing RCTs. They're probably not even going to be doing mixed method studies, but they could do implementation science in every single area that they're practicing in. And so this is an area that I think it could, using implementation science and helping to bring these principles to clinicians, can help to be able to bridge that gap. And we do need to get some academics on board with that as well. But this is I think it's an important issue, and it's something that we have to really address, because we have to study what matters most, and we have to learn how to make good care easier to deliver and sustainable. And we can't wait years for an RCT. And I've went into policymakers' offices and asked them, like to support particular things. And let me tell you, they're not going to read an RCT. But if I come in and I talk to them about a quality improvement project that I did with constituents that are in their district, that they hear and that they want more of. And so this is actually how we can make a difference, not only in the clinical level with the people that we're serving and in our organizations, but also at the policy level.
What do you think?
And I would just add to that, Dr. Seagraves, that I think that one of the things that we have really lost, and I will say that this is largely because of the unreasonably complex system of which the United States healthcare operates. There's, as my Italian grandmother would say, too many cooks in our kitchen. Um, but we've lost the idea that this is that healthcare, the delivery of healthcare is never an either or. I think that there is very strong space where our researchers, our rehab scientists need to keep doing that incredible work that they are doing. But that is not the only thing that is integrated into clinical decision making, right? Clinical decision making is the entire hierarchy of evidence, going all the way from what I personally experience day in and day out with my clients through the RCT, if it's even existing, right? We need to be better at not just being an interdisciplinary healthcare team, but being an intradisciplinary healthcare team. I need to be able to have information flowing from that scientist to me as a clinician, but that scientist also needs to have information flowing from me to the as the clinician to them. And that really it is the unity of both the hard science, the RCT, the mixed method that can be actually given the opportunity to take 10 years to do when evidence is then also supplemented with just as meaningful data from an implementation science study or quality improvement.
Do you both have actual, like, just tangible examples of where implementation science has been used within the occupational therapy field?
Yeah, I mean,
Go ahead.
I can give you many examples, even from like my clinic alone, right? So, I own a private pediatric clinic in a rural county, and there's a lot of different things that we've done. Most recently, we took a look at really with the rolling back of the Department of Education and the rolling back and decreasing of funds, particularly in the Medicaid area, which also helped to supplement pay for our services in schools, right? We took a look at how do we really improve the whole referral system to OT and PT with better understanding of the development of children, right? So we have this sort of conflicting story. We know that early intervention is best, right? We want to intervene early because when we intervene early, then we know that we can prevent further complexity of conditions or delays or impairments. But we also know that inappropriate referrals or referrals to work on inappropriate developmental tasks can be harmful as well and expensive and not provide the outcomes that we need. What we found is that we were having a ton of children in kindergarten being referred for things like handwriting, except for OT, except that developmentally, they really shouldn't be that good at handwriting at 5 to 6 years old. Like that's actually part of what they're learning how to develop. Likewise, PT was getting a tremendous amount of referrals based on like general body awareness and balance. Well, they're just exiting that sensory motor stage of development, and actually that's really appropriate behavior too. So we took a look at how could we still capture the necessary referrals from a developmental perspective and not having anyone fall through the cracks, but then also equally, how are we not wasting money on referrals that were leading to screenings and assessments that were really just indicating that children were developmentally where they were supposed to be, right? And so we worked through and implemented developmentally appropriate screens that were super easy. I'm talking like very, very easy language to understand, very much back to pen and paper, check, check, check while you're doing things. And then we would review those and start to, as a rehab team, determine, oh, we're school-based practitioners, we're looking through these, let's together decide what they needed. And could we minimize PT-OT dual referrals? Were there ways that PT and OT could split the referrals and make recommendations as to this might not be necessary for OT right now either? Then on top of it, we added in a whole program of handwriting that was delivered by one of our OTAs that was already in the school system. So we said, look, we're going to improve the workflow, just like Amy said. You're going to improve the workflow, right? We're going to improve the workflow, the referral process. We're going to create a very basic screen, and then we're going to come together in our case analysis and determine who needs to be evaluated and who needs to do the evaluation. And you know what data we were looking for? We were looking for reduction in referrals that did not result in a deficit that required intervention. And we had an 80% reduction in inappropriate referrals. Mm-hmm. Yeah. By just looking through and saying our workflow is failing and it's misusing funds. And then at the same time, to ensure that we weren't missing individuals, we were implementing a handwriting program that our OTA was doing while she was in the school. Here's the cool thing. She was doing it while she was working one-on-one with a student, but she was pushing into the classroom. So the entire classroom got to benefit from what that student was getting one-on-one services from her, but the flow of the curriculum she was using with him was benefiting the entire classroom. What were we looking for data-wise there? Did we have a reduction of late referrals in 4th and 5th grade? And we did. And so we're looking at how do we improve the workflow? How do we improve efficiency? Now you might say, oh my goodness, but wait, you don't want to how do you sustain a business? Well, we sustain a business because then what happened is there's conversation about how we are an efficient and effective group of clinicians who are providing just right care. So we get people who are calling, and we have more school districts because they say, oh my goodness, what an incredible process. And we're more effective with our treatments. So that means, like, when we say, hey, we're going to need to see a kid every single week and we need to be written into this IEP, we're believed because we've demonstrated that we're not willing to take on the children that don't need to be seen and aren't going to show the outcomes. And then our services look more effective because guess what? Our outcomes aren't muddied down by kids that never really needed the services the way we were delivering them.
Do you know, you probably don't, Dr. Stover, but I will tell you to believe me when I say this, is that what you just said, what you just described is so relevant to the bottleneck that we're in now, especially with acute care maternal health. And I'll tell you why. Because right now we have not a system in place, not a way to really determine who would be a best fit for acute care services at the time of delivery, within the first 24 to 48 hours before that a person goes home. And so what we're finding is that services are being started, hospitals are trialing these programs, but the therapists are not able to filter out, for lack of a better word, but filter out those patients that are really, doing pretty well. They don't need a formal, evaluation plan of care, the whole treatment plan with a rehab therapist. They're doing fine. They have a great support system. But then here are all of these referrals that we're missing, right? The one that may have lost too much blood, who had an unplanned, larger surgery than expected, whatever it was, we're not doing enough data collection or research or anything. We're trying to go right to an RCT to filter in and out who could be involved in our study and who can't be, but we haven't actually done. I feel like what you just described was the pre-work before an RCT. Am I right about that? Like, before you actually jump to an RCT, we're not saying that that's unnecessary, but what we're saying is there needs to be a way to actually capture what we're doing already. Am I understanding that right?
Yes, but I would actually rephrase it as we're doing the work of appropriately implementing the RCT, right? So the thing is we have so many RCTs that are done that represent that an intervention, a protocol, an actor can have a positive result on a system, right? Whether that's an individual body system or a process. But then we say in the real world, it's not working. It's not working. Well, right. Because we weren't using the appropriate systems to be receiving the RCT. So what we are doing in this implementation piece is we are identifying real time the process required to get the right people to have access to. Look, the interventions that you do with women who have lost a lot of blood in delivery or had an emergency C-section, these don't need any more evidence. You already are drawing on evidence that says that I'm going to perform an effective intervention for someone who has experienced deficits that result in these impairments. It's just about the fact of, are you getting the right people with the right deficits in front of you to show that your outcomes are actually truly reflecting that you are providing a meaningful and effective intervention? Well, no, not when we muddy down the waters and everybody's getting it, right? I mean, you could say the same thing with back pain, with a knee replacement. If we continue in this process that every single person just gets that referral immediately in that first 24 hours, we muddy down the effectiveness of our professions by showing these mediocre at best outcomes. Why? Because the person that's not changing, isn't changing their outcomes, the person that never needed our service to begin with. But the person who is changing and having the improved outcome that needed our service is decreasing the cost of the delivery of healthcare exponentially and decreasing the complexity of their future healthcare delivery, which at the end of the day, if I see a less complex patient more often, I'm not going to be as burnt out.
Mm-hmm. Yeah. And Dr. Seagraves, I would just say that I think when you were describing like what your current situation is with regards to um, maternal health rehab and who gets the services, who needs the services, who doesn't, it sounds to me like you are all already figuring that out, right? And so in some ways you're going to be able to, like, if you take your clinical judgment of what you're seeing, where it's not everybody who needs it, but it is the women who maybe had a longer surgery or they lost a lot of blood or they had complications or whatever the case might be, right? You're essentially in that space where you're in that plan, do, study, act cycle, right? And you're like, so our plan is we're going to make sure that all women who have these things in their charts are going to get a consult. And then we're going to go in and we're going to see, and we might work with them, and maybe you don't, and you're going to track it. And maybe you say, let's track it for 6 weeks and let's see what we see. And then you are going to you might add some people into the mix, you might take some people out of the mix, but it's that idea that you're continuing to really identify who is it who can benefit most from it. And it's not just an everybody gets it, because that's also part of the problem that we have with our healthcare costs rising, is that sometimes everybody just gets everything, right? And so we need to be good fiscal stewards of the limited dollars that there are, but we really need to make sure that the people who need our services the most are be able to access them.
I have no problem being this transparent with both of you. But Dr. Lamb, I've been probably one of the foremost, pushers on this to say, every person after cesarean delivery would benefit from an OT or PT consult. And, I'm in that pool of people now reconsidering, is that irresponsible, use of our limited staff, of our limited resources, to necessarily paint with a wide brush, and I have really been considering that because more and more therapists are asking questions related to barriers and related to doctors wanting to know, well, what value would you add? What else would you do that's different than what our nurses are doing or our maternal care team. And so I've really been thinking, well, there has to be a way to capture, these patients that would benefit. But how we do that, everything just in my brain, again, before this conversation, just went into these RCTs, these randomized trials where we would just test, certain interventions that we do or certain evaluations that we do, maybe a 2-minute walk test. And I say this to you both because I recently had a conversation with a PT researcher who just challenged me and said, well, if you wanted to do something like Duke University, what they did this year was they saved their health system over $500,000 by showing that providing inpatient PT and virtual or telehealth PT reduced the cost for readmissions over an 18-month trial period. She challenged me and said, well, if you're going to say that PT or OT had an impact on readmissions, you're going to have to find some assessment or some intervention that we do that can show we made the difference. It has to be something that we did that can actually be either calculated or quantified in a way. And I really have been sitting with that. Like, what would that be? Would that be the impact, 6 clicks? Would that be a 2-minute walk? And so my brain became very small at that point. I couldn't really see much bigger than that problem.
Yeah, and I appreciate you sharing that, and I think there's definitely a place to go with being able to identify like what are the interventions, right? But there's also an element to be able to say like, I love that you are rethinking your initial thought that like you're not changing your mind, you're rethinking, you've gained new information, and so you're thinking about this workflow change. Like, is it an automatic referral for women who had a C-section? And we should rethink things, because when we learn more, when we get more knowledge, we should be challenging ourselves to rethink things, right? So pick that one workflow change, right? And you say, like, we're going to track it for a month. Automatic referrals, you're going to track the reach, how many people received it, what was the process like from the time of the eval or to the first visit, from the referral to the first visit, and what was the outcome in terms of like maybe length of stay. And then you're going to review it monthly, and you're going to make modifications, and you're going to repeat it. And that is implementation science as underneath that quality improvement label, right? But the question about, what is it that we do that is going to be distinctly different than what other people are doing? And so that we can show that we have this almost magic intervention that's making a difference, right? Sometimes our intervention is making someone else's life easier. So, for example, when we can push in, a nurse might be freed up to be able to do something different with a mom on the unit. And so I like to think about, like, I love to talk to the different players on my team to be able to say, like, what is your top pain point as a nurse on this unit? I want to know from all of the different people, like, what are their pain points? And then I want to find out, how could I use my background as an occupational therapist to intervene to make that pain point a little bit better for them, and also make a difference in this mom's life, right? And that's really where the magic comes in. So sometimes it is that we need to come in and offer some services so that we can free up people to do something different that they also have to do, right? So again, it's improving workflow for them, but it's also allowing us to use skills that we have at the same time. I don't know if that makes sense, but
yeah, and Dr. Seagraves, I would add to that, right? Like, I think that the answer is that the type of outcomes that individual was asking you for exist in science, but not in implementation, right? So when you take a look and we say, how did the U.S. government even determine or define what is going to really equate to best care, right? And you look at the triple aim, and they said, look, yes, we're going to need to have a good intervention or delivery of care, but what does that look like? Well, that looks like anything that will improve the health of the population, which, just as Dr. Lamb said, is inclusive of that nurse who now has the ability to really provide the level of care, expert care, because she's relieved of additional duties that aren't that could she do them, yes, but aren't really in alignment with the expertise that she's been hired on to do, right? So now mom B in the next room is actually going to have a better outcome because the nurse is freed up to do what she has been expertly trained to do, right? It says, is it going to decrease costs? So yeah, that looks at outcomes like readmission rates, length of stay, actual number of dollars spent, how many bedding changes were required, how many bandages were required, how much time in the OR was required, right? Like your outcomes are actually looking at decrease of cost, and then it's patient satisfaction, right?
Mhm.
Because we know that a patient is not going to report satisfaction if they're actually in a worse experience of health and wellness. And even just the component of believing that I'm satisfied with my care can actually then create more health and wellness for me, right? So I say the outcomes that they're asking for, no, it's not the sit and reach, it's not the 2-minute walk test, right? It's patient satisfaction, it's cost of care. And sometimes, just as Dr. Lamb said, it really is looking at the data that says when OT and PT were present, cost of care went down and patient satisfaction went up, right? And that's what you're looking for. And I think the other part of that too is feasibility and acceptability are the outcomes that we're looking for in implementation science. Was it acceptable? Was it able to be done? Was it feasible? Were people happy? Were they satisfied? Was there greater knowledge? And finally wrapping that in, I think this is what starts to bridge the question of just right care delivery. So you're starting to see that not everybody needs care or OT or PT right after delivery or right after a C-section, but how do we capture those ones who do? Well, is there something that you can start to educate, implement, or do with less cost, less time earlier on, so that now me as the patient, I'm even thinking about it. And maybe now I'm educated in the capacity of saying, oh, I'm going to ask for one because I remember those red flags, right? What have we done with postpartum depression, right? We've actually empowered the patient themselves to be more aware. We're having the conversation before postpartum. We're giving them indicators, red flags, knowledge, so that they are more participating in determining if a referral is necessary. And isn't that really the best indicator, the patient themselves to say, I need help?
That's absolutely right. We do so much patient education before major procedures, and postpartum or perinatal mood and anxiety disorders are something that people are more informed about. You're absolutely right. I want to bring this all full circle, and Dr. Stover, this is going to kick it to you first because I've been having a really hard time with this last question, but there was something that you just stopped me in my tracks. My jaw was dropping, and it was looking a bird's eye view, specific to occupational therapy practitioners, but a bird's eye view of the investment and the value potential that we're going to see in the next few years. You were saying that with me when we were in person talking about this, where other countries are collecting data and looking into how can we invest more in occupational therapy as a field. Can you almost like help me close this conversation with some of what you said? I think it's really valuable for a bigger audience to hear.
Yeah, if I'm remembering correctly, and Dr. Lamb is very familiar with all of this work as well, and has had great opportunities to engage with many of the leaders. But recently, occupational therapy as a profession had an incredible win in the country of Norway, in which Norway started to recognize sort of this dual experience of health and wellness, that yes, we have the diagnosis experience that really then is facilitated through your PCP, right? Your primary care physician, the individual who's checking those blood markers for indicators of certain disease or disruption in health, right? The individual that's tracking sort of the physiological responses of the body to things like perimenopause and hormonal changes, things like that, right? But then Norway's also really recognizing and understanding this functional component of health and wellness. And they're saying now that in order to participate with the least amount of cost to the individual themselves, and they have a very different payment system, but in very concrete and I'll put it in a more Americanized terminology, right? Like, so when you go to your annual visit, whether it's your annual gynecologist visit or your annual PCP visit, like you don't have a copay, you're rewarded for that, participating in that preventative health. Well, Norway is also now rewarding you for participating in your preventative annual occupational therapy visit too. So they're really looking at it from this dual aspect of the diagnosis of health and wellness, as well as the functional implications of health and wellness. And when we have the conversation annually, right, about that functional health and wellness, we actually can prevent chronic condition from exacerbating. We can prevent or catch early certain conditions, impairments. We can actually prevent disease processes from occurring. And sometimes that actually requires us knowing that your sleep's disrupted way before your hormones elevated.
Dr. Lamb, ending with you, do you see primary care occupational therapy becoming standard of care in the United States in our lifetime?
I do, actually. It's an area I'm incredibly passionate about. I think that in my conversations with PCPs, I hear them say that when I talked about pain points earlier, right? Their largest pain points are that they're allotted 10 to 15 minutes to see every client. They can't begin to understand everything they need to know about that person, the context that surrounds them in those 10 to 15 minutes. So they need help because they're booked for every 10 to 15 minutes that they even have, right? They also tell me that they don't know what to do with their patients who have some cognitive decline, who they're not sure they're understanding the directions or those sorts of things. So they can't follow through on lifestyle changes because they don't really comprehend them, right? And then you have the people who might not be compliant with lifestyle changes that are being recommended or medications that they're supposed to take for a variety of reasons, right? Like there's a variety of reasons why people do not take medications that they're supposed to take. And if we spent 30 minutes talking with them, we'll find out more about why they're not taking them, right? And this is where I think we can really shine the light on like occupational therapy in primary care. When I talk to a patient in primary care and I'm meeting with them after they've met with their primary care doc and we're talking about maybe a chronic condition that they have and the medication that they're taking and the lifestyle changes, the mom doesn't tell me that she's not taking her medication because she doesn't want to take her medication. No, she wants to take her medication, but the medication actually makes her feel really dizzy and drowsy. And she has to drive her kids to school. So when she gets up in the morning, she takes her meds and she puts them in her pocket. She gets her kids into the car. She drives them to school. She drops them off at 2 different buildings. She gets to work. And what happens when we get to work? Everything starts coming at you, right? She never remembers to take the medication, gets home at night and finds it still in her pocket. It's not because she didn't want to take it. It's because it didn't fit into her lifestyle. And when we can find that out, then we can say, let's think about how to adapt this routine and what that might look like different, right? Like maybe it's where you leave the medication. Maybe you have some of the medication that just automatically stays at work in a little container that you visibly will see, right? Regardless of whether or not you have people standing at your door. So like those are some of the really key things that I think are encouraging to me because I know that PCPs are stretched thin and chronic conditions are on the rise. And I know that there's a lot that OT can do about it. And we need to push in, and we need to push in and not say, like, I have an RCT here behind me that tells me that you need me. We need to push in and say, I have skills that we can use with your clients, and we can trial it for 6 weeks. And let's see where our outcomes are on these 3 areas in 6 weeks. And then let's decide what we want to do with it moving forward. And that's really kind of the piece about thinking about pushing in. But I really do think that we will see a more normalization of the use of occupational therapy in PCP for sure.
After that description, I don't see how we can, why we wouldn't be pushing forward now, really. Both of you probably know that rehab leaders, hospital leaders especially, will gain a tremendous value from this conversation that we had tonight. Both of you should know that. But this was a consultation call starting out for me, but it ended with just immense value that you provided to such a larger audience. Knowing who your audience is and any last things that you really want them to take away. Is there anything, Dr. Lamb, that you want to leave these leaders with when they're really grappling with where to go from here, especially with such a new emerging area of maternal health, and even looking towards the future of what we just ended on with primary care? I think there's so much opportunity we're not tapping into. Is there anything else you want to leave
Yeah.
the audience with?
Yeah, I think, I'm hopeful because, there are issues surrounding maternal health that if they weren't in maternal health, we would have solved them. But policymakers are like not always women, right? But we're seeing more and more women in policymaking seats. And so we're seeing more people thinking about how do we address the needs of women differently? And how do we make sure that our policies are inclusive? Birth is one of the most physically demanding events that anyone experiences, right? And so we oftentimes, I think, discharge women before their function actually catches up with them. And so when OT and PT are integrated, it allows moms to go home safer. It allows them to go home feeling more confident with less anxiety. It allows nurses to have less strain and the units to be able to run more efficiently. So I don't see it as a luxury to be able to include OT and PT in maternity rehab. It's something that we need to have because it's a safety and equity intervention, and it's going to protect patients, staff, and the system overall. So that's where I see this going, and I'm so excited to be able to be on the front end of a conversation as this area is growing, because I think it's so needed. So thank you for having me.
Thank you. Dr. Stover, any last takeaways, valuable pearls that you have?
Yeah, I would say that first and foremost, complexity does not equate to efficiency. And so I would encourage administrators, rehab leaders, hospital leaders to really think about what is it? What is it? What is that simple thing that we can implement, try, measure? And it doesn't have to be this complex component, but is it just measuring length of stay? Is it just measuring patient satisfaction? Is it measuring patient confidence? And the other thing that I would say is, I completely agree with Dr. Lamb. Look, this is an area that we have long known can really be indicative of entire population health. Maternal health has a direct link to population wellness. And I don't want us to think about the complexity or where we feel we haven't been, or if there isn't an RCT, and wait as long as we did with things like fall prevention in the older adult to realize that we have the expertise, the intervention, the right care to ensure that maternal health is done well. We just need to implement it.
Mhm.
Don't be afraid to be the leader doing it. We already have enough stories that show it's going to work. Be the courageous leader that's willing to say, I know that maternal health equals population wellness.
Thank you so much. Thank you both so much, Dr. Lamb and Dr. Stover, for your time. And really, I mean, if there are, more requests, I think like this, I will absolutely direct people to this interview with both of you. Really, just as a first stop. But is there, are there ways that you're making yourself available for these more, higher tier conversations? When we're talking about hospital administrators, we're looking up even those CFOs who are meeting with our rehab directors. So for their sake, would you both be willing to consult with these higher tier professionals? Would you? How can they
Yes.
reach you?
Yes, absolutely. Allison and I can share our contact information with you, and you can share that. This is a space that we've really been able to join together on because we're both very passionate about it, and we also both come from a very systems-based lens, and so we think about systems, and so we love to talk to people who are looking to make their systems more effective and efficient. And when we can link that with wellness and population health, like that's the trifecta for us. But we can share our information with you so that they can reach out if we can be of any support to their efforts.
Wonderful. I'll link that in the show notes. And again, thank you both again.
Yes.